So welcome everyone to the panel discussion in the track Creating Value Through Digital Innovation in Healthcare at the 16th International Conference on Business and Information Systems Engineering. It was a pleasure, or it is a pleasure to have this panel and to have been able to chair the track together with Hannes and Ivor. The spirit of the track and the panel basically echoes the recent observation that if we look into research on healthcare IT in the IS field, we do see a lot of research that has been done, but it has been done in there's a rich tradition of research on healthcare IT in the IS field. And if you look at how this research has been carried out over the last decades, there is a certain focus that is tangible in the literature, in that it has focused on many issues that relate to hospital information systems. So we do know quite a lot about adoption, acceptance, and use of information systems in hospitals. We do have a bunch of studies on implementation of hospital information systems. And we do also know quite a bit about resistance to hospital information systems. So we do have, at least I think in my perspective, a pretty well-developed body of research that is pretty consistent in that it finds, by and large, I would say, that doctors and managers usually disagree on issues that somehow relate to the implementation, the use, or the management of these information systems. So we do have a lot of research on healthcare IT. I think this is pretty clear. However, if we look into recent dynamics in the healthcare space, we do see some new and very, very interesting phenomena, starting with the importance of and diffusion of electronic health records or electronic patient records, going into the observation that data has become very central for transforming healthcare practices. And if you look at it more conceptually, you'll quickly see that data is not necessarily the same as information technology or an information system. It does have subtle relationships to that, of course, but it's not necessarily to be equated. Likewise, we do see that if you look at classical hospital information systems, these artifacts often play the role of providing support functions. And somewhat classically echoing what the digital innovation research community is arguing, data become very central, not only in providing support functions, but in actually making decisions, therapeutic decisions, and other decisions that matter for creating value in healthcare. And so we have many new artifacts that somehow relate to data, such as machine learning algorithms, platforms, and diverse consumer IT that have become really, really central in how healthcare-related practices are changing throughout the recent years. And when putting together this track and thinking about a potential panel discussion, we thought, what would be an interesting focus? And we quickly realized that it could be very interesting to look in more detail into the role or into the relationship between data and value creation in healthcare. And we also thought very quickly that it could be very interesting to call on some leading practitioners in this area or leading field experts that have actually been very much involved with creating value from data in healthcare and invite them to our panel. And it's a big, big pleasure to be able to welcome a very, very renowned set of panelists to this discussion today. We do welcome Dr. Amonida Tsadiza, who's a Senior Strategy Officer for the European COVID-19 Data Platform. I think the importance of her work cannot be underestimated in this time, as COVID-19 has brought to the fore quite drastically the importance of data and somehow coping with new insights into mechanisms that underlie the pandemic and diverse forms of intervention. So it's a very, very big pleasure to have you here. Welcome to the panel. And likewise, it's a big pleasure to welcome Dr. Oliver Gröne to this panel, who is the co-chairman of the board of the Optimedis AG. Optimedis is a leading provider or leading company in the area of transforming healthcare through data and data analytics, so through healthcare analytics. In Germany, the company has established several integrated care networks where they very successfully managed to integrate different data sources from information systems in doctors' offices into a data warehouse and running several analyses on the data and trying, for example, to predict when a certain incident might kick in and how the patient could be prevented from experiencing it. And when I say this, Optimedis has been doing this for over 10 years. So it's a very much a torch-bearing company in this regard. So it's a big, big pleasure, Oliver, that you agreed to join our panel. Thank you very much for this. And then we're very humbled to be able to welcome three very, very renowned researchers to this panel as well, to discuss with us together about the future of research that actually relates to healthcare IT. So how can we discuss these insights that we get from the field experts from a more conceptual lens, and where will perhaps the trajectory of research on digital health move in the information systems field? And it's a big, big pleasure to welcome Professor Andrew Burton-Jones to the panel. He's the editor-in-chief of MIS Quarterly, one of our absolutely leading journals, and is a professor at the University of Queensland in Georgia, and has done a lot of research on the digital transformation of healthcare in recent years. And it's a big, big honor to welcome you to the panel and the VE conference. Thank you very much, Andrew, for joining in. And then it's a big pleasure to welcome Ava Oborn, who's also the co-chair of this track and a senior editor at the MIS Quarterly Journal. She's a professor at the Warwick Business School and has done a lot of research on digital healthcare as well. She's done a lot of work on the relationship between professional practices and healthcare IT, and more recently on the role of digital innovation in healthcare. Ava, thank you very much for joining the panel. We're very much looking forward to discussing with you. And it's been a pleasure to be able to run the track with you. It was really cool. Thank you very much. And I also welcome a good friend and longtime colleague, Ali Sunyaev, to the panel. Ali got his PhD from the Department of Informatics at the Technical University of Munich, was then an assistant professor at the University of Cologne, and then a full professor in Kassel, and now at the very renowned Karlsruhe Institute of Technology, and was one of the first German research to actually do research and publish research on electronic patient records, and has from there developed a keen interest into the relationship between digital innovation and healthcare. He has done work on genomic data and its role in transforming healthcare practices, and other digital artifacts that relate to somehow moving forward the healthcare field. So welcome, Ali. It's also a great pleasure to have you here. Thank you very much. I suggest with the panel, we would like to start with having a brief introductions of our field experts, so Amonida and Oliver, into the particular fields of work that they are doing, and based on that we would then move into the panel discussion. Amonida, could you start?
Yes, of course. Yep, I'll share my screen. Right. Right, you should be able to see my screen now, and let me just make it into a full screen as well. There we go. Right, well, thank you very much for inviting me to participate in this panel about this very, very timely topic. So as you mentioned, Larry, I am based at the European Bioinformatics Institute, which is part of the European Molecular Biology Laboratory. And we do big data in biology. I think that the kind of tagline really says it. But just to kind of give you a little bit of background on what we work with more closely. So the data resources that we have at EMBL EBI range across a kind of a very wide range of areas. Now, we have expertise in dealing with biological data for over 2 decades now. And these areas are ranging from literature, so publication records, one side through providing molecular data, access to the data in terms of both kind of archiving, depositing the data, but also adding value and enriching that data through our knowledge-based databases. So you see kind of through this flow, you have literature on one side, molecular data, archives through it added with our knowledge-based databases. And at the other end, we have drug discovery, where we actually provide all our data resources through the Open Targets platform to our industry partners. Now, one of the missions of EMBL EBI is to provide all of this information freely available. And that is something that I really want to, excuse me, emphasize and point out, and which is relevant to the discussions that we're having, is to be able to make the data that we store freely available, but also in addition to that, the tools and the services that we provide as well to scientific community, to anyone who would want to use it. Now, our involvement with the COVID-19 pandemic and how we got engaged with it really started back in March last year. So this slide really shows kind of the flow of our this particular project, the European COVID-19 data platform. So on the one side, we have the data providers in form of universities, research centers, and hospitals and public health laboratories, where the data kind of flows through the data resources that we have. So that's the kind of the middle panel. And then all of this information is then provided through the COVID-19 data portal and then available again freely to the user community. Now, the important things to highlight here are a few things. One is that for this project and this kind of, I guess, our commitment to provide or tackle the pandemic, we really didn't have to initiate or put something together. And that was because we already had the infrastructures, we already had all these data resources available. So a lot of efforts were into repurposing the data resources that we have and adapting to the potentially new types of data. So all of that was in place, so which made this process extremely quick to make, and again, to basically make the data just, it was really simply, it was kind of a matter of putting up the website for the data portal. The other thing which I want to highlight in this slide is that we follow the concept of as open as possible, as close as necessary, and that comes with data, which I think it is again very important to bring up here as well, because we are aware of the sensitivity that is attached to human data, that it needs to be, the privacy of the participants and the patients need to be respected. So we do have mechanisms and systems in place that deal with human data, where we provide access control data as well. And again, this was also not something that was new. These were kind of mechanisms that we already had in place. So really, in terms of I guess topics to think about, and hopefully we will also discuss them, is to how to make this idea of open data more acceptable to the different participant in this data flow that you see. And specifically, I am thinking about, and that's also what you mentioned, Larry, in your introduction, is the public health professionals, clinicians and epidemiologists, for example. How do we make them more willing to share the data? Because that's kind of one of the things one of the challenges that we are facing at the moment. And the other thing is really, I mean, without having the biological data, none of this would be possible, right? And now it's really the time, or really, I should say, we really don't have, we cannot afford kind of holding back on important data sets, because, you know, there are lives that are being perished, and we really need to collectively come together to make this process happen. I think I will stop there, and then we'll bring up some of these topics later on when we have the panel discussions. Thank you.
Yeah. Excellent. Thank you very much, Amonida. As indicated, we would like to proceed by having the field experts present the organizations and the work they do. And then if you have questions, we'll ask them collectively after both presentations, and that would be very good. So thank you very much again. And Oliver, would you like to introduce Optimedis very quickly?
Sure, we'll do that. Just a moment.
Very good. Thanks.
You can see my screen? Okay, perfect. So thanks, Laurie, for inviting me to join this session. I'm going to present briefly our model on population-based integrated care. In the introduction, you talked a bit about the existing knowledge base on hospital information system and IT transformation. I think at the primary care level, that is an under-researched topic in many ways. And if you look at the connectivity between different sectors, it's even more under-researched. And I hope that our work can lead a little bit to a reflection on how this could be developed further. So what we're doing really is that we are working mostly in the German context. And as Laurie said in the introduction, we are setting up integrated care networks. Why are we doing that? The German healthcare system is often seen as a very good healthcare system. The ministers always say this is one of the best in the world, as they have to say, because they're the ministers. But if you look at the data, for example, the OECD data, we are pretty good in one dimension of their reporting, which is the cost of our healthcare system. We are amongst the most expensive healthcare systems in the world, after the USA and after Switzerland. If you look at the series of quality indicators from the Healthcare at a Glance series by the OECD, we're usually on somewhere in the middle, with average performance indicators on health outcomes. And that is particularly due to the fact that in Germany, we have a very strictly separated primary care system and secondary care system. And you find good doctors and good infrastructure in both, but they're not well connected. And that has huge implications on the care being provided, particularly to people with chronic disease. And this is really where we step in. As a company, we set up integrated care networks that aim to bring together the different care providers in the region to align their workflows and to think about different potentials to optimize care, particularly for chronically ill. So we are really driven by two major questions. So the first question is, what if professionals, in addition to their professional knowledge base, actually learn from each other by sharing information and by reflecting on the outcomes? And secondly, if we were to implement processes that support that, what if the work in the integrated care system would be rewarded based on the outcome it achieves, rather than on reimbursing different individual episodes, such as fee-for-service at the primary care level or DRG-based at the hospital level, which actually provide disincentives to integration. So these are the two overarching questions. And in order to address them, we have developed a data warehouse that you can see here. Doesn't look very spectacular if you look at it from an international perspective, but in the German context, that is quite an achievement, because we have been able to pool data together from primary care, from health insurance companies, and the health insurance companies are in a unique position in the German context because they have data on primary care, secondary care, rehabilitation, sickness periods, and so forth. And it provides longitudinal data on the insured. We use this data to provide feedback reports to providers, to professionals. We then have quality circles. We have individual discussions with GP practices on how this data suggests certain areas for improvement. And we also, do further analysis and reporting and prediction models and all the things that you expect someone to do with data. The second point of that is really that we have a business model agreed and negotiated with insurance companies where we are being paid based on the achievement of certain targets. And these targets are basically reflected in a long-term aggregate quality indicator, if you want to, keep it simple. This work has been, as you can see on the right hand, being reflected on or being received by various international organizations. We are best practice model by the EU, recognized by World Health Organization and World Bank, have been also been reported on at the World Innovation Summit for Health and others. And the key component of the work we're doing is really, which you can see in the heading, is to use data to conduct analysis, creating insight and generate value. Now, if I go to the next page, this is really that is reflecting the stream from data to value, because usually healthcare systems are based on the processes. You have a patient, you see the patient, you do everything that is according to the professional knowledge base, and then you're being paid for that episode of care. In our context, given that we have this overarching value-based financial model, and given that we have the data, we can afford to look from the top, from the outcome that we want to achieve, and then going backwards really. So given the certain outcomes we want to achieve, what are the processes that are required to reach these outcomes? And given the processes, or given the structures and the current levels of demographics and comorbidities, incidence and prevalence, how can we create these processes to generate these outcomes? So it's basically putting this kind of logical or causal logic on the top and really giving a very strong emphasis on outcomes. That is also reflected on the triple aim model that we're using as a basis to structure our work. So the triple aim is focused on not just improving patient experience, but simultaneously trying to address three different goals: improving the health of the population, reducing per capita cost, and improving patient experience. It's not easy to just focus on one dimension of the outcomes, but it's much easier than trying to balance three outcomes. But I think this is really the innovative component, because there are many organizations or many models that help to improve patient experience, but perhaps at the expense of health outcomes at the population level or at the expense of the economical outcome. So balancing these three outcomes is really one of the key. In our models, we save about 5 to 7% of health system expenditure annually. And we've been doing that for more than 10 years. We have a very high level of patient experience, and we're even able to demonstrate an increase in quality of life and length of life based on sophisticated analysis. So I want to stop here. Maybe this is enough food for thought to look at the implications of setting up a system. And back to you, Larry.
Thank you very much, Oliver. That was a very good introduction into what Optimedis is doing. Are there any brief understanding questions, any clarification questions to Amonida and Oliver? Just raise your hand or type them into the chat. Okay, no clarification questions. That is always good. Then we would move into the panel discussion, which Hannes will kindly moderate. And if there's questions to the panelists from the audience, then please be so kind and type them into the chat. I will take care of them, that they get asked, and will talk to Hannes so that the questions can be asked. So just if you have a question, type it into the chat. That would be great. Okay, then I would hand over to Hannes to guide the panel discussion.
Thank you so much, Laurie. Thanks also for the nice presentations up front. Hi, everybody. Thanks also to all the participants for joining in, as well as everybody that has joined in as a viewer. But as Laurie mentioned already, if you have questions, if you have something that you would rather have been discussed, please open up in the chat or use the Q&A function in this Wova tool, and I will point to Laurie once in a while to take then over and send some of the questions in from the viewers. Okay, so with that being said, so there are already, as Oliver mentioned, there are a lot of food for thought already, and I would like to first give back some questions to the field expert, and then lead over to the IS research, which tend to have more of a regularly more of a higher level perspective on that, and I guess you have also some thoughts on that. So we have now seen like two completely kind of different examples, but working with different kinds of data in healthcare. And I think this makes healthcare nowadays pretty interesting. So because we see now there are a lot of there's a diversity of data that we could now use to create interesting services or drugs or vaccines, as we've learned. So Amanita, I have seen something very interesting on your, I mean, there are a lot of things interesting in the slides on the funnel, right? So there were, but something kind of strikes me. You kind of work in the domain where you, on the one hand, have like open data, and you also have this, how did you phrase that? It's not proprietary, it's controlled data. So, which seems to be like a conflict, or there is some kind of ambidexterity there. So could you maybe elaborate a little bit about how do you operate with open data versus like this proprietary data?
Of course. So so are you thinking, you're thinking of the human data, right? I guess that's kind of that. Yeah. Okay. So so we do. So when it comes to human data, I mean, there are a few things that we need to keep in mind. First of all, human data, and let's call it patient data, or what clinicians collect, do not leave the national borders of a country. That's how things, because it is sensitive. So they are highly protected, and rightly so as well. I think that is very important to respect. However, what can be shared openly is a level of metadata about the human data, which is could be, we're talking about, for example, a few of the identifiers could be age, could be sex at birth, could be demographic settings, and so on, health. Potentially kind of, previous health records or issues. So, and these are the things that can be shared because they are not attached to the actual patient directly. So, and these are the things that we do have systems in place that can handle it, and that is kind of that's also the type of data that can share, that can be kind of leave the national borders of the country and be kind of collected and used by other groups as well. So there is one way of dealing with it, which is, and then you can kind of see that as a level of open data, because that information is available. Another way is on actually including this level of kind of openness is that even for this type of open data, as a user, you have to sign up and authenticate yourself, or where your affiliation, where you come from. So there is also a very secure way of knowing who has access to these particular data sets and how they are going to use it as well. So it is, so that's why it's called access control data, because you're controlling who's accessing it. So in that sense, it makes the data available to the people that actually work with it, but it also has this different layers of securing the data, so they're not come out into the open as such. Does that answer your questions?
Yes, very much. I mean, it opens up a ton of new questions, I guess.
Hopefully I can answer them.
So one of the key takeaways for me is like it's a lot about data sharing, and I think this is also where maybe Oliver also jumped in, because you talked a lot about data sharing as well, but your providers of this data are completely different, right? So can you tell a little bit about who's providing that data that you use? What kind of data is that?
Was that a question to me?
That's for Oliver then. So like,
yeah, okay.
I try to break the transitions.
There are certain data sources that we're using, and some of it is actually publicly available. There are lots of databases on secondary data that you can use at the regional level, and some of that we use, and it can be quite informative. And it's probably one point that I like to bring in the discussion, which really bugs me sometimes, because we are always striving towards sophistication of data merging and analysis algorithms to get the data right to the 5th column after the comma. Sometimes that is not needed. Sometimes with very simple data, we can take decisions that improve health service delivery. That's maybe just one aspect to answer that question. But the key data that we are actually using, and that is part of the discussion here, is health insurance data. And health insurance data has some advantages and disadvantages. The advantage is that once you have data sharing agreements in place with the insurance company, which is a completely different story to get there, you have a very long and comprehensive longitudinal data set, which allows you to analyze in depth certain requirements, demands, supply side factors, and allows you to infer a lot about patterns of utilization and opportunities for improvement. So that is one of the key data source. And it's also the key data source that we use to estimate the outcomes that we achieve and based on which our business model is working. In addition to that, we use a range of other data sources. Some of it might be directly extracted from GP practices. Again, that is quite complex in the German system, because we have so many different systems being used by GP practices that are not interoperable, and then getting this data in a uniform format to work with that is quite challenging. Well, we've done that in the past for various projects. In addition to that, we can use hospital data. Some of that, again, is publicly available in the German healthcare system. For example, data that allows you to look at admission rates. And that is interesting again, because within the hospital context, we look a lot at clinical procedures and outcomes. Some of that can be quite complicated. I've done work on that in the past in the UK, but just by knowing who is actually admitted to the hospital, that's very informative. If you see that a large proportion of patients is admitted to the hospital with a diagnosis of diabetes, heart failure, high blood pressure, COPD, asthma, you get a feeling that maybe other parts of the healthcare systems are really not doing their job properly by default or by other design factors. So this is the hospital data. And then in addition to that, we use survey data on representative population-based surveys to look at patient experience and PROMs, patient-reported outcomes, healthcare quality of life, and finally registry data, if available, to look at survival outcomes. So this is a whole range of data, but the backbone of the whole thing is the health insurance data.
Wow, thank you so much. That was for me also very insightful to get this picture. I've learned. I would like to transition over for the first time to the IS scholars as well, because maybe we start with you, Eivor. So you have worked a lot on health infrastructures, and you know a lot about sharing data as well. So what is that we can learn? Is there something new that we can learn here, or do we know a lot about sharing already that that is nothing really new for healthcare? For the IS scholars when we look at this type of sharing?
Hi, yes, I assume you did say Eivor, right? I wasn't quite...
Sorry, yeah.
Yeah, no problem. Yeah, hello, thank you for the question. You know, I guess a key issue here is also the use of data. Of course, it's important, but it's also about how people use this in response to a crisis. And I think one of the the fascinating things about healthcare, and why it's a area that is so interesting to study, is there is such an array of stakeholders, and these stakeholders operate with different goals, different needs, and they want the data for different purposes. And I think it's very interesting from an academic point of view, perhaps, is to look at, for example, how their dominant sort of institutional logic sort of drives what kinds of problems they face, and therefore what kinds of data seems relevant. And then also, to push it further, the data in and of itself, and I'm sure Oliver can relate to this, is to the extent that this data seems usable in the practice context, and various stakeholders will have unique areas of practice, and therefore what seems straightforward data and being able to integrate it isn't necessarily so from the perspective of practice. So I think that, in that sense, data, yes, but actually the technical part of the data and its actual use to transform practice is often not the hard part. It's understanding how do we integrate this, and part of that might be through the various logics that stakeholders take hold of, or that might guide them. And then also thinking about how then do they integrate that digital and the data part with their ongoing analog processes, which they still need to take care of.
That brings us to a very, I think this kind of sharing perspective like opens that up, right? So you have different stakeholders you bring together, and you just kind of assume that it's kind of a technical thing, bring data together, which it maybe is not. I would like to bring in Andrew to that conversation as well, because you have worked in that domain as well quite a lot, and work particularly on effective use on these kind of systems, right? So now we have these kind of complex systems that use these different stakeholders. What is your perspective on that?
Yeah, well, first of all, I just wanted to thank Amanides and Oliver for the presentation. I mean, it was really super interesting for me in Australia to listen to both of them. And they both resonated with me as well. I can see similar kinds of initiatives in Australia or related ones. And so I think one of the reasons so many of us are interested in this area is that in each of our jurisdictions, we see similar things, but we also see differences. And so that's quite powerful. Look, I think you started off the panel talking about kind of where we've come from in IS research, and that there's been a lot of stuff on EMRs and hospitals, and that kind of maybe we're going to have a big shift. But I don't see that really from these presentations. So both of the presentations really still have a kind of essentially an organizational focus. It's just that the organizational unit is larger. So it may be a system of organizations. It could be the organizations that crossing primary and secondary care. It could be the aggregate of organizations. So where can we get data from all different health services in a nation, perhaps maybe across nations, but it's still an organizational problem. And on one hand, that's really important, because organizations are important in society, and organizations are responsible and important for solving these healthcare problems. And it's just that essentially it's a larger multi-level problem now. Previously, we looked at it as a smaller multi-level problem, maybe, wards within hospitals, hospitals within a health service or something. But now this is much bigger. It's a larger multi-level problem, but it's still an organizational problem. I guess that's comforting that it's sort of essentially an extension of what we've done to date. On the other hand, you could challenge it and you could say, well, look, organizations tend to reproduce the status quo. There's conflicts of interest in that organizational system as well that lead us to sort of not deal with what the real problem is. So just as an example, people who are on this panel will know that the amount of money that goes into acute care versus, say, preventative care is not the way it should be. So we, rather than actually help people who help people stay well, we help people who are sick, kind of thing. So rather, what could we do to flip it on its head and really focus on wellness, for instance, as opposed to treating people who are sick? How could we take not just patient experience in the healthcare system, but actually look at this from a patient-centered perspective? So it's not even patients anymore because they're not necessarily in the health system, just person-centered perspectives on wellness and so on. How can we really flip the logics? And this relates to Ivor's question about logics. There's a real logic driving the current systems, which is around patients and the healthcare system that provides for those patients. I guess coming back to the question of data, it's really interesting because depending on how far you push it, the meaning of data changes and the nature of data changes. So, the way that clinicians talk about data for a particular disease or syndrome or treatment is very different to the way that a consumer, an individual person, may think of themselves and the data about themselves, their own experience, the meaningfulness of something to them, their intuition about something, the emotions they attach to things, the connections with other people who experience similar feelings. These are very real, important parts of our daily life that we all experience, but we don't see that data in these systems, right? And even prems and problems don't really get at that. So, I think it's really interesting for us as IS researchers to say, what can we do to support the organizational problems as these organizational problems scale, so they become larger multi-level problems? But then how can we help flip the system as well and think of, what data, what algorithms, what systems could support change in the system so it's more person-centered? And if we can do either of those things, then we'll be helping a lot.
Wow, that was, so there's definitely something that we're going to pick up on. I've just learned that Michael has to leave in a couple of minutes and you have something burning under your fingernail. So Ali, if that's all right, I would go to Michael first. Okay, thank you so much. Michael, then I would lead over to you. I just learned that you have
Thanks so much, Hans. And no, I didn't mean to interrupt the flow. I just thought I would throw in a question as I was leaving to be taken up. It was really just to connecting, and thanks to everybody for the presentations, really insightful. But connecting the first to Amanita and Oliver's question, it was really, again, to Oliver, the extent to which you've seen your different types of models that you've suggested there. Have you repurposed and adapted them in crisis? Linking back to what Amanita has mentioned, I was quite curious as to what's happened in the last year.
It's an interesting question. In fact, we haven't at all. That has various reasons. One reason is that most of the response to the corona crisis in Germany certainly was organized at the national or at the regional level, and the scope of functions that we could fill was by definition more limited. Had we had more opportunities, we probably hadn't acted more. Secondly, a lot of the work in the regions was done directly through our partnerships with the doctors who are co-owners of the integrated care management organizations. So it wasn't really so much based on data, but more on organizational issues. And here we did see a response, because as integrated care networks, we were able to reconfigure which practice is doing what. In the absence of these forms of collaboration and organizational networks, there was real confusion for the GP practices. Should I see people with COVID? Should I vaccinate now? Can I do that? Will I be a testing center? What happens to my other patients? All these questions. And in the context of integrated care, we were able to sit together with the doctors that formed the networks and say, well, this practice will become a priority practice. This practice will become a test practice. We work together with mayors to say, well, let's use the school, which is closed anyway, for a testing unit. So that was a response to the COVID crisis, but it wasn't a response that affected us as a headquarter of the integrated care networks, because our work simply continued in collecting and producing our data reports as much as possible. And we didn't have a lot of data that say on the testing or now on the vaccinations that would really help us be more proactive? So it's more an organizational response rather than a data response, if you wish.
Amanita, do you want to react as well to the question?
Yeah, sure. I will add that, yeah, as I mentioned, it was for us, it was more repurposing and kind of adapting to the situation. So, for example, we already had a pathogen portal that was in place. So what we did was to kind of, repurpose that for, and make it dedicated to SARS-CoV-2 and COVID-19. When it comes to, I guess, making the COVID-19 related data available. But along with that, what we also did, and this is an ongoing process, is to initiate multiple conversations with European countries. And this was really, so what we did, and as I said, this is so ongoing, is to initiate through our network of collaborators, a series of meetings where we meet with a dedicated national coordination teams from each country. So we meet every month or so, where everybody kind of, comes together, and we're talking about, I can't remember the number of, but we are, let's say, almost everybody in the EU, definitely, where everybody kind of shares what they have, what's going on at national levels, any changes when it comes to testings, how the progress in their sequencing and sharing of the data as well. And also, of course, a very important element of that is also the policy making, the national policy making efforts as well, and how these different efforts can connect to each other at a European level, but also take advantage of each other's, tools and services and that are being made available, and respecting again the fact that not every country can progress as quickly as they can, because of course, the challenges are very different.
Thank you very much. No, really interesting responses there. Thinking about the different levels, right, all the way from regions through to national to between countries, and the way in which data becomes relevant alongside organizational practices. So really appreciate your answers. Thank you again.
I think it also I also that we have these very different levels, right? So there is this COVID platform that has a European that has the complexity of integrating all this data from the European perspective. And then we have, but still a highly complex system that is even a regional perspective. So how do we build this kind of multi-layered systems that can span across these different layers? When we see that each layer has this high complexity, is super, super interesting. Ali, so I would guide over to you. So you have experience in omics research. So looking at omics applications as well as other healthcare IS applications. So one thing that I would be very curious on is then with your experience, is this, so how, like looking at these different cases as well, so how are these kind of healthcare systems now kind of designed? Has this kind of changed? Is this now, has it become more complex, and do these systems have to be designed differently? What is your kind of experience there?
Yeah, so let me first say that I really enjoyed the two presentations. I enjoy very much the discussion. And Hannes, before I answer to your question, let me kind of sort the questions we discussed before. And I would first like to say something with regard to data sharing. And I think that, well, and coming back to the question, of course, we talk to the guys who really work with the data. So not only the clinicians, but also the researchers in this kind of biomedical community in Heidelberg. It's not only MBL. We talk to guys from the Harvard Medical School or the German Cancer Research Center as well in Heidelberg, who maybe work with this omics data, so with all these genome sequencing techniques. And we actually, that's not that they don't want to share the data. But of course, they first want to get the Nobel Prize from working with their own data, and we can't blame them for this. And we also can't blame, like, you know, all these data protection regulations that are out there. From my perspective, it's good that they are out there. It's more like the question, what can we do from our side to enable data sharing? You know, use some decentralization. Amanita mentioned some, you know, access right management, kind of giving the governance with regard to data, not to the guys who maybe gather it, like all these Facebook and Google do, but maybe to the guys who kind of donate the data, right, to the patient, and then they decide. And if it's not about incentives or whatever, if you understand for what and how your data is used, you maybe even will be okay with sharing it, especially if you're doing something good like research. What I also missed in the discussion is that nowadays a lot of data is actually produced outside of this professional healthcare environments. All of us and all patients produce huge amount of very valuable data. You know, think of all the sensors and kind of smart watches and smart devices and smartphones and whatever. And of course, they are very, very valuable. And you know, it's a combination of these different data sources that kind of leads to kind of even some behavior change. That's what we are also interested in from the IS community, right? So it's not only the kind of human genome, it's also the social genome. And so if you kind of smoke 100 cigarettes a day and don't do any sports, or kind of, you know, don't have a healthy lifestyle, which of course influences your health and your medical condition, maybe even more than your kind of, you know, kind of genome setting. And regarding the COVID-19, I wanted to say that we are actually right now on a crucial point, because if everybody speaks right now about vaccinations, and this is the exit of the situation. But we had the whole year where the society expected actually us to deliver a problem, to deliver a solution to such a problem. You remember all these contact tracing apps, all this idea on how to kind of deal with this virus. And I would find that we are not seen as failed. You know, of course we are theory driven, and of course we use evidence before we kind of speak or write. But this is something where we maybe should have done more, not only regarding the data, but also with regard to being an advisor of such developers, because it's not a technical problem, actually. That's what we see. It's again a social technical problem, right? And Hannes, I promised you to answer your question as well. So with omics data, it's like with every data, you know, it can be visual data, it can be kind of just electronic health record data, like, you know, some text, it can be omics data, it can be whatever data. It's still a sensitive information. And there is techniques how to deal with sensitive information and privacy preserving tools, even with regard to the AI agents. So I think that what it is actually about is helping to produce huge amount of high quality data. That's what's actually also crucial. And of course, for all this kind of statistical tools and methods, like, you know, machine learning or deep learning, they actually all rely on huge amounts of high quality data. That's what they need. And maybe that's also how we can try to help. Thanks.
Amanita, did you want to respond? So,
yeah, I did actually, and thanks for that, Ali. That's actually also you highlighted some of the challenges, and I think, you know, not just for us as a kind of data repository of biological data, but for us as, you know, people who are on this panel and the audience as well, is to acknowledge that these challenges do exist. And I think, Eivor, in your talk, you did also refer to them. What are these barriers that the clinicians and epidemiologists, for example, do face, and they need to also have this clear for them. So what are the benefits for them to share their data, for example? And the way I see it, I think there's, we can probably divide them into three different groups. So there's this cultural barrier that, so historically this data hasn't really been shared. The patient data, it always either stays with the GP or with the hospital, and it is also a lot of this kind of crossroad between information system technologies that are being adapted across healthcare providers, hospitals, and so on. But for them to see that sharing their data is beneficial beyond, their immediate environment. The other issue could be technical, that there are actually there is willingness to share the data, but how do you actually go about and share the human data that you are sitting on? It is extremely useful, but how do you go about and share this data? And I think that is, that's the other gap that we need to really close in to make for example, the system that I described, this access control data mechanism, available, and also bring that kind of gap closer to each other as well. So people know that there are ways for them to securely share that data. And then the third barrier to me is legal aspect of sharing the data as well, especially when it comes to human data, respecting GDPR, respecting national legislations, and how, again, this is something that we all really need to consider and be aware of. And how do we overcome these issues, which have to be respected? Of course, there are very good reasons why these issues are, there are legal, limits or restrictions or regulations in place for very, very good reasons. But then again, these are the things that we really need to think about. But then at the same time, being aware of them, but to see how we can actually make the data still available, so it is actually useful for the research community, for the healthcare professionals, and for the wider communities as well. And then there's this wonderful, other area that you touched upon, Ali, which is linking the biological data, the healthcare data, to the social sciences field, which we haven't kind of really touched upon, but that's also something that absolutely needs to be brought in as well, because we can't really just look at this as a health issue. This is something that is affecting societies at multiple layers, and I think that's also something that we need to be aware of. Now, how do we make that connection to these kind of outsider data types as the way we look at it?
I would like to there were a lot of different things, different aspects that we could discuss, but in the matter of time, so we have to kind of focus on some of them. But I would like to aggregate some of the things that have been said and reiterate that to you. So Eivor talked about the different logics and how practices and data is used within different logics and then kind of shared, where logics might collide, right? Andrew, you said we have a system that is on sickness rather than wellness. So if we want to create a wellness system, that would be kind of a different logic. So that would be a collusion, right? So how can we use data that was created or practice that were created in a sickness system and then use that in a wellness system? So I'm asking myself now, what kind of systems do we establish to make that transition? Are there systems already kind of in place that help us make repurposing, we use that term a lot, easy? Is it something that just happens? So how can we make that transition? I'm just asking myself, because it seems that systems and data play a lot of role there. So it plays an important role. Oliver, you unmuted, so maybe you can go first.
Yeah, thanks. And sorry, I wrote something in the chat, and somehow the corrective technology changed the meaning of the text and the words a little bit. So apologies for the typos there. But to answer the question, I think some of you touched on that, which is the patient's role in this whole business. Healthcare in all over the globe is very traditionally and paternalistically defined and structured by the professions. And as long as this remains so, it's not going to change fundamentally in terms of realizing patient-centered care. So I think the move towards a real health system rather than a sickness system requires a much stronger role of the patient empowerment. And the first step to that is, full access to all medical information on my own health. I need to be able to access my records. So many countries have passed legislation to facilitate that. In Germany, we're still lagging behind. It will still take years to have full access. And that's just the technology side, let alone the culture side. Secondly, I think Ali mentioned that about the data that is being collected by patients already on the iWatch or through other devices. There's a huge amount of data on physical activity, on sleeping behavior. You can do your EKG on the watch. All that is being collected. And that would be a very powerful source of data to redesign the system in the future, and possibly also to provide more incentives towards more a health system. And the third component to make that work is really to bring this together in an interaction with those professionals working in the sickness system. How do we bring these two words together of patient data, focusing on the social context, as Monida also said, on the health context in which they're living, together with the healthcare system context, and bringing patient and professionals together. That really requires a paradigm shift. And I think these three components really are required to move towards a system focused on health outcomes.
Thank you, Oliver. Andrew, yeah, please, go ahead.
Oh, I just couldn't agree more. I think it's 100% completely agree. Can I make a different comment though, Hans? So, you've created an interesting panel here. We have some eminent people who are working in this area, and then you have some academics. And I guess my critique would be for the academics. So not the individuals, the individuals obviously amazing, but the field. So if Amanita or Oliver picked up a copy of MIS Quarterly, which is the journal I'm associated with, they will be dissatisfied generally with the solutions and insights we provide them. And you could say, well, why is that? And it's for a number of reasons. It's hard to solve that. But one of the reasons is that we do have a sort of reductionistic approach to science in general. And that's not just in our field, but in many. So we study small problems because small problems can be addressed in 30 pages or 40 pages or something. Unfortunately, the problems that are true problems are big problems. And you could think, well, maybe I could address this over like 5 studies and sort of string them together. But research is so messy that we can never actually do that. We never have full control over how these 5 studies work out. Usually we're exhausted by the second or third. So we need to formulate ways in our field so that we can address these big problems. And we need to have editorial structures and review structures that support us publishing papers that address these larger problems. And it may be that addressing a larger problem roughly is better than addressing these small problems well. Now that's a kind of a hypothesis we haven't been willing to test in our field. We tend to do small problems well, and that's the sort of reproducing the status quo in our own field. So the challenge for us would be to say, okay, let's see if we could tackle some of these larger problems roughly, get some insights that would be helpful for people like Amanita and Oliver, and that could then inspire future research. It may be that over time, we can start to address these larger problems well. So that would be, I guess, the challenge for me as like an editor of a journal, and maybe myself as a researcher as well. one of the ways I can imagine trying to address that is looking at larger team research, cross-jurisdictional research, more interprofessional, interdisciplinary research. And again, that's a weakness in our field. If Anita or Oliver were to look in our journals, in general, we don't do that. So yeah, so that would be the main two comments I would say.
Thanks, Andrew. Aver, did you want to reply as well, right?
Well, yeah, I guess I had a number of thoughts that I could say, though also in the interest of time, I think that, you know, maybe 2 points. One is that maybe a challenge that we haven't actually mentioned, but I think actually sits in here too, is the financial or the business model that sits around a lot of these functions. And one of the reasons, for example, why patients might not really engage with, you know, well, this is my data, is because, you know, we're not sure clearly as a patient where the value sits for them. And the whole value creation model when it comes to the economic value being recouped on this is unclear. So even if we understand the legal issues, the technical issues, and even if we can solve that really hard, the actual purpose of use, you know, how do I actually integrate this into practice, which is a lot of, you know, my interest in the research sense, the whole business model wraparound, and it came up, you know, it was mentioned, you know, the IS community maybe could have been part of solving this sort of track and trace and the use of apps and the rest of it. But what we really saw were large companies that were actually telling countries what could and could not be done with certain forms of data. And this, you know, it's a different sphere. It's certainly not my area of expertise, but integrating, you know, some of these real issues that are part of data, which is in a sense how the value capture in economic terms, which drives a lot of the stakeholders in here. And even hospitals, you know, they're trying to be more efficient, and GP practices, they're also co-owners in this system, for example, that Oliver was describing. So the economic interests are clear. And I guess the other point I also wanted to mention, you know, trying to change the use from the person, so that a user-centered healthcare system, a challenge again for the user as a potential patient or family caregiver, is that for them, the data practices are holistic in their life. So they don't define out, you know, a 30-minute segment of their week or their day to say, okay, now I'm thinking about my healthcare data, so let me, you know, change my behavior pattern to think towards healthcare data. And so we mix up whether it's my data for jogging or I'm going into my bank app and then healthcare, but healthcare sits so much outside of the rest of this in the way that we construct it socially. And I guess in a key message that as consumers get taught about their other data uses is that, you know, there's breaches of information. You got to watch your bank statements, things are coming in and whatnot. And so the challenge for the consumer is also shifting from healthcare as this side activity with wellness is just me and my life. And that's, you know, that consumer group is large because that's the whole population. Not just an institution that we can change the rules of. Anyway, I'll stop with that.
May I just?
Oh, Andy,
sorry.
do you want to respond first?
Yeah, I would like to say so many things, but let me just bring in the IS perspective, which is kind of most important to me. It's kind of our community. We are talking a lot about research that, with the facts that we speak about are from communities like, you know, medical informatics or public health, health policy. What about the IS field? And you mentioned, Hannes, the keywords like, you know, acceptance and use and trust questions and privacy and so on and so on. But I wanna take the chance, as I see Andrew here. I very well remember his paper published back in 2014, where he picks up on this theory of smart machine that was proposed by Zuboff, like, I don't know, 3 decades ago. And Andrew, you kind of state that this theory in particular is still kind of underutilized by the IS researchers. You know, like 8 years have passed since then. I can't say there is a lot of papers that kind of are doing theory-driven research using even such kind of, you know, theories that are very well received by kind of several communities. And what we didn't speak about is, like, you know, all these work practices and the change of work practices for healthcare professionals with regard to all these new technologies. And of course, it changes the way they work. So it's, you know, do they just trust the algorithm that provides this kind of a suggestion for a therapy? Do they still think whether it's right or not what the AI agent did propose? What about all this, you know, omics data we spoke about? Do they, so the practice is completely changed. Before they ask the patient what is actually happening, they take a look at the data. That was completely different, like, you know, even 10 years ago. And we also may think of all the consequences of this transformation, because the transformation of, you know, how they do their work, because it's not only affecting them as professionals, affecting not only the whole, you know, medical and health industry, it's also affecting us as a society. Because, you know, so even, so I better speak of myself. Before I go to a physician, I ask some services on the internet, or I just look up. So do we will need this in the future, or do we only will ask, and for the majority of all the cases, we will get a right answer without kind of seeing a physician? So there is a lot of unanswered questions that are, I think, very interesting from the perspective of information systems research. And it's kind of sad that even if I write papers, I cite a lot of papers outside of the community, and there is kind of not a very coherent literature stream in the IS literature that focuses on digital transformation in healthcare, medicine. It's kind of, you have to search for it, or you kind of see healthcare just as a context, not as the unit what actually people are researching about. So I brought in some controversial and some further questions, Hannes, just because I also saw Andrew here and I wanted to mention this as well.
Yeah, before I give over to the audience as well, because we have a couple of questions. Andrew, do you want to quickly respond?
Look, I just really appreciate Ali's comments. I think it's really nice of him to mention some of the work that I had tried to essentially, I had tried to say that some of the old theories in the field are still very relevant today, and I believe that's still true. And in fact, my personal belief is when we talk about digital transformation being a new thing, in fact, I tend to think of it as an old thing that we've been studying all the time. But, you know, it's so important in our field to look at things in new ways as well, and to be willing to change our ideas, to test ideas, improve our ideas over time. So I'd be delighted if I saw a paper that showed that some of Zuboff's work still apply in digital transformation of healthcare, just as I would be delighted to see a paper that said her ideas no longer apply and that the different ideas apply. I think that's the way science evolves. I guess the main thing, and this relates to a comment that was in the chat Anna had put down, but was really that we may need to look beyond just IS, you know, to have a broad view of our field. So to bring in, you know, practitioners to work in a more engaged fashion with practitioners, to work with people from other fields. You know, if we want to say this is an information systems project, well, you know, we can lead it and then it's an information systems project, or we can support our colleagues, you know, and publish, let's say if it's a practitioner colleague that we're working with and they want to lead it, well, we can publish in one of, you know, in a leading practitioner kind of journal or outlet or a report or government report or something. We can, if we want to support our medical colleagues or our nursing colleagues, we can team up and they can lead something. But we want to be part of an engaged ecosystem in which, you know, each of us can lead in our own ways to make, you know, positive outcomes in the world, in our communities, but ultimately for the, you know, the communities we serve. I certainly think we all wear multiple hats, right? So, I'm an editor of a journal, but I'm also a researcher who wants to make a difference in the world. And some of that will involve, things that I think of as IS research, but some of it will involve me publishing in healthcare journals, or me writing government reports, or me doing, we all have these multiple identities, and we're trying to find the best way forward.
Thankfully, you already weaved in some of the comments in the chat, but I would like to give Laurie the chance to, because you kept view on the questions.
Yeah. Excellent, thank you, Hannes. Yeah, so Anna Penninger asked basically the question that Andrew provided the answer to, so how to involve practitioners or other stakeholders more actively in delivering knowledge contributions. But there are some other questions on the chat. So Linda was the first who posted a question, and that relates to her seeking professional advice, so to speak, from the panelists on the question whether the planned donation of data to a data center in Germany is an adequate measure to address the current COVID-19 pandemic, which I guess is a big question. But I'm also curious to hear what our panelists think about it.
Maybe we start with the one who is the field expert there. So Amanita, you are working with this data.
So I'll be happy to give my my viewpoint. So it's as an individual, you usually will consent that, when your data is being taken, blood samples or whatever it is. So, and in that sense, that with that consent come also the fact that you allow that data to be shared by the hospital, the research group, in the way that they see it fit. So now the next level is, how do we then make sure that this information is actually reaches the wider community, because that's kind of what we are talking about. Like, again, how can we make sure that the data that an individual has actually willingly shared makes its way through the different layers of legal side of things, technological aspects, so it actually reaches the research group beyond the initial group that is working on this. And I think that is one of the challenges that we are facing now, and that's one of the topics that comes up as I mentioned, these national coordination meetings that we have. And this is one of the topics that almost every time we meet with all these experts from different countries, this is one of the topics that we discuss: how to make this link between an individual's data to the research that is being done, to the data that's being shared to the wider community. How can we make that link so it is secure, it is smooth, and let's not forget, quick as well, because that's the other thing. I mean, especially now, we have got vaccines, but it is just us. We have got the wider world to think about as well. So how can we make that process as smooth as possible, and keeping in mind all these different aspects of that need to be considered, legal aspect, technical aspect, going beyond, and also creating this level of trust for people. And I think that's also very important. So as an individual, I feel comfortable to share my data, but as a research group, it's the same thing. I feel comfortable, I have trust in this system, that it works and that it reaches the people that it should, and it's also used appropriately.
That is super interesting, particularly because we're talking about data donation, right? So the term donation is very special because it might be used for whatever reason thereafter. I think so. Ava referred to it as data fore. I like that term. That was very interesting for me. Laurie, do we have another question before?
We have a question by Scott that relates to that, who asked, I think it's also mainly, or Amanita could be in a good position to answer to that. What about sharing data that does not only affect the individual, but also the families or other persons that in the immediate surrounding of the person who shares the data?
Sure, I put a very short description in the chat as well. So usually it really does not matter if you're an individual that is participating in a studies. So usually they're called the cohort studies. So it's if you give your consent to be part of a larger research project, I think Oliver mentioned also some of the longitudinal studies, as they're called, then, and some of them also include your immediate relatives or your parents, children, siblings, and so on. And the same level of data security and consent applies to all the individuals that participate. So, it doesn't really matter that, if one person has consented, it does not automatically mean that all the other people involved in their immediate family would also kind of consent. It has to be on individual levels.
Thank you.
Maybe just a second. As far as I understand, and that's because Scott and I actually working on this topic, it relates to genomic data. And with genomic data, it's so as far as I understand, also a little bit different, right? So I might be okay with sharing the data, but my brother maybe not. And there was multiple cases with, this Golden State Killer and so on, who were actually only found because one of the close relatives used this 23andMe and kind of, they just saw, well, it's kind of, I don't know, 50% the same data as the killer we are looking for, and that's how they found them. It's not the person, but it's a very, very close person to the guy we are looking for the last, I don't know, 4 decades or what. So, and this is how it may affect your relatives directly, or isn't it?
May I, just very quickly? I mean, yes, absolutely. It is about the genomic data, and there is, historically, we have had, some episodes of the history that we really don't want to perhaps remember, but it is the fact that, a lot of patient data were taken without their consent. So, and I think that is one of the reasons that we do see this mistrust that, how will my DNA be shared? And this is one of the, I guess, another challenges or battles that societies need to work, especially when it comes to ethnic minorities, for example, and across. This is something that we have seen is like, how will my data be used, and what are the advantages for me? What do I get out of it? And I think that is again something that we need to overcome. But in terms of whose data will be shared, if you do not consent, I mean, there is I think one of the first such studies that was kind of at a global level was the 1000 genome study, which became kind of the reference study, where they looked at triplets, so an individual and their parents, and anyone who was not comfortable sharing their data, they were kind of excluded from this study. So, and I think again, that's something that we really need to emphasize, and we really need to reach out to the communities who could potentially, their participation would be very informative, but there are a lot of barriers that, especially when it comes to trust, that we need to overcome for them to participate. So it's absolutely, this is something that we definitely need to work on, and it will take a long time to achieve as well.
So looking at the time right now, so I would kind of want to wrap up. There are a lot of loose strings that we could still discuss, but this is actually good because it means that we can do a little bit of research. But I like looking at these threads already. Is like I would like to hand over to maybe first Aver and then Andrew. So you both have a lot of editorial experience already and seen what has been published, what is potentially going to be published very, very soon, maybe. What are the kind of, so what is that currently happening, particularly in times of crisis, where we see, okay, this is maybe changing what we already know on theories? What is the kind of trend? What should we do? What should we do as IS scholars now, beyond your more critical aspect, Andrew? So I don't know, maybe Aver, do you want to go first?
Well, I guess it's a tall order to, summarize what do we do now. I think, it was interesting what Amanita said. She brought up, this issue of trust. The historical context shape how we see things. These sociological tensions remain. So there's a lot of, these are mainstay areas of understanding the relevance of, for example, trust and use. I certainly think in relation to COVID in particular, one area that I think is very important to watch is sort of this, what I might call the recalibration process. The new normal, and how do we establish a new normal? We've kind of been on this, okay, we put a lot of things and expectations and maybe practices on hold, which might relate to privacy, it might relate to surveillance, it might relate to a number of issues that we've touched on, and even our willingness to engage, for example, in trust relations. But how do we recalibrate this, and where do we then go? Like, are we going to go back to the pre-COVID days? I doubt not, BC as we might call it, but how does the system adjust? I think there's a lot that we can learn. I don't think that we've studied crisis response at a wider level in terms of integration and transformation. So, COVID has clearly transformed healthcare in ways that CIOs have never managed to in the last 5 or 10 years. There's been dramatic changes in practices in many ways. And so, this sort of external jolt, if you will, of a crisis and what it's actually doing and how it drives us, either for adjusting response, is it the agility, is it the mindset, or is it the integration of multiple stakeholders in a very complex system to create a new frame, i.e., we're in a fight and we're fighting together. So there are some of these interesting ways that we can understand how framing can integrate diverse stakeholders. So these are some areas that I think are important research sort of topics and spheres, and I do think that they can feed directly into many of the issues that Amanita and Oliver presented us with how do we go on, how do we get these stakeholders to buy in, and how do we solve some of these more social as well as legal aspects that might sit before us.
Thanks, Ivor. So maybe, Andrew, do you want to have the final word?
Sure. Look, I just wanted to thank everyone for doing this panel. I think it's been terrific. Look, I think you asked what the sorts of things that MIS Quarterly, for instance, that our journal is doing, or what's sort of coming out. So we have a special issue on digital resilience. I noticed in the panel, in the audience here, Panos is there, who's helping lead that special issue. So I think that'll be a really exciting special issue to come out, the sort of leading edge thinking on what digital resilience means and how organizations can achieve it. Look, I think in terms of what researchers need to do, I would use the word that I used previously, which is leadership. So I would say IS scholars should combine with other scholars of their choosing, whether these are people in whatever field it happens to be. It could even be, we talked about patient-centeredness, members of the public or groups in the public. It could be policy makers, people in government or private industry, and to lead those networks to help appreciate problems or help solve problems. And we could have problem appreciation type work, we can have problem solving type work, but only through actually leading that work can we have sort of an IS angle to it, just as only when the medical colleagues lead that work will they have a medical angle on it, and so on. And through setting ourselves up in networks where we can take these leadership roles and where we can take supportive roles, then we will make a difference. As editors, I would love us to, when we see that sort of work that's showcasing that leadership, that we will do our best to publish it. So that would be what I would say. In terms of my own personal interest, that's of much less relevance, because it's not me as an individual who's accepting these papers and things. What I would say, though, as a little trend I've seen, I've only been the editor-in-chief for a short amount of time, but despite our understanding of the importance of data, I actually see surprisingly few studies on data. There's more studies on algorithms, more studies on use, more studies on organizational topics. The nature of data actually is often just taken for granted. And data is really interesting. And historically, our field has had something to say about data. So I'd love to see some more studies on data. I'll just leave it at that.
Thank you. Thank you so much. Thanks to the entire panel.